Thank you, Dr. Namrata Madam and Dr. Sinha for uh, this session. And I'll be talking on the slit lamp examination, that is the hidden master key. Actually, all of us all the time are focused on so much of intricate and sophisticated investigations that sometimes we tend to overlook the very basics and something which is right in front of our eyes. So while trying to save the sight, we also need to make use of our own eyes and catch something which could be subtle or very obvious. Uh, when a patient, presents with classical symptoms of a red eye, a middle-aged man complaining of a painful red eye, especially after watching movies in a movie theater, and feels like a typical migraine case, and also complaining of headaches, then the diagnosis is not very difficult. Probably it's a case of angle closure. So good history taking might sometimes lead you to the diagnosis. A very classical case again with lid edema, congestion, chemosis, edematous cornea, a very shallow to flat AC. The pupil is also classically dilated, vertically oval, sluggishly or not reacting to light and accommodation. The iris is edematous, discolored. Again, the diagnosis is not very difficult. This is a case of acute angle closure, but it is those subtle signs when everything put together also sometimes may not lead you to your diagnosis, or you don't know why your patient is not responding to your treatment. You have done everything possible. So you need to remember that at the core of everything, all the investigations remains a good and thorough slit lamp evaluation. Now, what are the roles of doing a good slit lamp evaluation? It could be, of course, only to see whether glaucoma is present or not for screening or diagnosis, to re-examine a case for any additional or subtle findings which we just saw you could have missed and you want to decide whether to start treatment or not, for a differential diagnosis, to stamp the type of glaucoma that the patient has, what is the probable pathophysiology and the etiology of glaucoma, to see the degree of damage, to plan your management, and of course, after you have started management, again to reevaluate your treatment. So coming structure by structure, what are the different diagnoses that your slit lamp evaluation can tell you? Coming to the lids, lid edema, of course, it can perhaps be a case of acute angle closure or uveitis. But you also need to remember that around the lids or on the lids, there could be drug reactions, because many of us now use PG analogs in our patient. Brimonidine is known to cause this typical periocular dermatitis. These types of reactions may in fact warrant discontinuation of the treatment. Such kind of a periocular pigmentation, it can be very discomforting comforting to patients, especially if they are young, they are females, and if the condition is uniocular. So you also need to look at these conditions, and which will help you to see whether you need to discontinue and modify your treatment or not. Of course, inflammatory and infective conditions, because if you're planning to do surgeries in these cases, all these need to be treated, because they'll affect the success of your surgery and may even lead to endophthalmitis and blebitis. Latanoprost again induced long lashes may be very cumbersome to young females. And again, as I said, if these are uniocular, a patient on brimonidine typically complains of foreign body sensation. So when a patient complains of this symptom, you need to always invert the lids and see for in the fornices whether you can see the follicles or not. This is very important, because sometimes foreign body sensation, burning and discomfort are taken as vague and non-specific symptoms, and we just tend to prescribe some placebo or lubricating drops to the patient. But always try to invert the lids and see, and you will see the typical follicular conjunctivitis of brimonidine. So again, here you may either want to discontinue the treatment or switch over to a lower concentration of the drug. Coming to the conjunctiva, dilated episcleral vessels, which could be there in thyroid eye disease or in a carotid cavernous fistula, again, which suggest increased episcleral venous pressure, and these can also be a cause of glaucoma. Pre-existing blebs need to be evaluated to see for how much is the probable filtration, what is their thickness, what is their extent, what is their vascularity. And sometimes the patients, especially if they're coming from rural areas, they're illiterate, they don't know what surgery is done in their eyes. They just know that some operation was done. So it is very important to again raise the lid and see what lies underneath. And you might see a filtering bleb sitting there. It is also very important to examine the conjunctiva for your selection of filtering bed if you're planning to do surgery in these cases. And especially in vitrectomized eyes, those have buccal sitting there. It will be very helpful to pre-operatively decide where you're going to make your window. And again, in cases of unresponding cases, you just avert the lid or see deep in the fornices and you see a steroid depot sitting there. So you just keep on adding medications to the patient and you don't know why the patient is not responding. But probably there was a depot which was given, which perhaps might need excision. The ciliary flush, very common in angle closure glaucomas and acute rises of IOP, even in iridocyclitis. Everting the lower fornix, sometimes you can see discharge sitting there, even if the patient does not complain of frank discharge and matting of eyelids. And nowadays, with lot of use of prostaglandin analogs, and nowadays even with the rho kinase inhibitors, there is a lot of conjunctival hyperemia which is coming up. So all these patients need to be counseled that this hyperemia is not inflammation, it is not toxic, not allergic, but it is just a simple vasodilatation. And even a long-standing use of BAK in the anti-glaucoma drugs, they can cause surface inflammation. So here again, you might want to either switch over to preservative-free drugs or friendly preservatives, or perhaps some other molecule. Examination of the sclera, again, very important. You can see often these staphylomatous eyes. So if you're planning to do any surgery, you might want to consider pre-operatively where you'll be making your incision and the surgery, what would be the use of the dose and concentration of the antimetabolite that we will be using, if at all, or you might want to perhaps go for an alternative like Ologen. And again, in cases of scleritis, you may want to consider treating these conditions first rather than going for an intervention. Cornea, as we just heard from Dr. Vijay Lakshmi, corneal edema, of course, a classical sign of an acute rise in IOP. You can even see stromal scarring and ghost vessels, and the classical horizontal or oblique harp stria, which are signs of ophthalmos or a previous rise in intraocular pressure leading to Descemet's stare. And in the young patients, the children, pediatric cases, you need to differentiate these from the injury due to forceps, which cause the vertical stria. On the endothelium, you can see the KPs, which are suggestive of acute or past uveitis. Careful examination of the endothelium, especially under high magnification, you can see the Krukenberg spindle. So this is a very classical sign of pigmentary dispersion syndrome, which will, you know that you need to evaluate this patient further. You can even see pseudoexfoliative material sometimes on the endothelium and a classical beaten silver appearance in the ice syndrome. This case, of course, it needs further evaluation. We know that this is a case of correctopia, and you can see the classically prominent and anteriorly displaced Schwalbe's line, suggestive of Axenfield's anomaly. So not only in the patient, but you have to do a complete family screening for this patient. In the anterior chamber, of course, the von Herix is very, very important. I'll not go into the details. We all know what are its gradings. So it could be a grade 4 where there is a very low risk of angle closure, or just half the thickness where there is a low risk of closure. But you can have a slit like von Herix also, or a totally shallow to flat anterior chamber, where you definitely need to investigate this patient with gonioscopy and see what are the status of the angles. Von Herix is very useful for screening, especially for suspects, and to identify who needs a gonioscopy. But it is very important to remember that it is not a substitute for gonioscopy. Don't just classify a case as open angle or closed angle just on the basis of von Herix test. There could be false positives when you feel that the von Herix is grade 4, but actually it could be a case of plateau iris. When you do the gonioscopy or the UBM or ASOCT, then you find that there is a peripheral closure which is there. Or it could be negative. That is, you find that the von Herix is just grade 1 or 2, but it could just be a thick iris which is there, which is giving that appearance. So always do a gonioscopy. Von Herix is not a substitute for gonioscopy. Again, a classical case of uveitis. You can see the ciliary congestion, the AC flare and cells. You can see all the typical signs that are there of uveitis. In cases of trauma, you can have hyphema, and sometimes this frank hyphema may not be there. But after you are doing a follow-up gonioscopy in this patient, you can see blood clots in the angle, or you can even see that 8-ball hyphema which still persists. So even after this frank hyphema is resolved, do continue to follow up this patient. With lots of vitrectomies and gases and oils going on, you can again have inverse hypopyon or a PFCL. Again, it is very important here to raise the upper lid and see even the upper angle of and the upper limbus also, because sometimes a very subtle inverse hypopyon can be sitting there, and if you don't raise the lid, you can just miss that out. Not very uncommon nowadays. The Emerth valve tubes and the express shunts are there. You need to see how well they are placed in the anterior chamber, their contact with the endothelium and the iris, and whether their orifices are blocked or they are closed, or where there is a surrounding synechia. Iris atrophic patches of various types could be there. You can have this classical iris, sectoral iris atrophy because of previous attacks of angle closure, or you can have iris atrophy because of the eye syndrome or the Exenfields, etc. So all this will tell you that this patient definitely needs further glaucoma investigation. You can see different kinds of pigment deposits and nodules on the iris surface, and even a heterochromia. So again, you need to do a rule out whether this is just a simple melanosis, it's a nevus, or it is a malignancy. And always remember that in cases of such heterochromia, always compare both the eyes. This image, you can see it's a classical case of Fuchs heterochromic iridocyclitis. So you can see the stark contrast between the two eyes. So always compare the pigmentation that is there between the two eyes. You also need to look at the iris contour. You can sometimes see this convex iris, you can see a iris Bombay, or sometimes you can see a concave iris configuration. And in both of these cases, not only do you need to do a gonioscopy later on, but you also need to do a YAC PI for both the cases, for a pupillary block as well as for a reverse pupillary block. So your good slit lamp examination will guide you to the treatment also. You can see either peripheral anterior synechia or posterior synechia in a case of uveitis. Sometimes with long-standing posterior segment pathology or an ischemic problem, you can see rubeosis. This frank rubeosis and fresh large vessels are not difficult to miss. But sometimes in suspecting cases, you need to carefully examine the pupillary border under very high magnification, and you will see these vessels lying there. And even here, you can see just a single vessel which is lying, which will tell you that now this patient is going into a case of neovascular glaucoma, and your management will entirely change. And along with that, you can also see that a localized ectropion is also developing. So the ectropion could be either sectoral or it could be a 360-degree ectropion. Again, a pigment dispersion syndrome, you'll see the classical church window defects, the transillumination, and you can see that loss of pigmentation as well. In cases of trauma, or even if there is no history of trauma, an iridodialysis should suspect a history of trauma, and you should ask for the history further. You can see localized nevi, and this is a classical case of inferior temporal iridoschisis. So this can just be missed out as a local iris atrophy and you can ignore. But this is a case of iris iridoschisis, which you again need to investigate further. And again, not very common these days. You can see those tubes sitting behind the iris also, which are tubes in the sulcus. Pupil, again, you need to see the shape, the size, the number, and overall how they are reacting to light. It's a case of classical correctopia. So again, this is an anteriorly displaced Schwalbe's line. You can see the surgical PI is done. And sometimes, the PI is not visible and the pupil is slightly, you can see it is updrawn towards the site of the filtration window. So this suggests that probably the window is getting closed or is already closed with that iris tissue, that you can see that peaking is there. So again, here you need to do a UBM, OCT, and of course a gonioscopy and see whether this needs intervention or not. The PI patency, again, either direct examination or through retroillumination, and sometimes even multiple key PI can be there, and especially inferior PI in cases of inverse hypopyon. This is a very subtle sign that many of us actually tend to miss. This is how a normal pupillary border would look like. It's a corrugated appearance and is known as the pupillary rough, that irregular surface that you see. But many times, this is of course a classical iris atrophy that you see. But many a times you can see this is smoothing of the pupillary margin that has happened. The rough is there only in this part and the rest of the pupillary border has become smooth. So this smoothing of the pupillary border is actually a sign that previously there has been an episode or multiple episodes of increased IOP, which has led to the loss of that rough. So this is a classical sign of probably occludable angles or angle closures, and which definitely need further investigation. Again, another case you can see here, the pupillary rough is there in the rest of the portion, but here there is the margin has become very smooth. So these subtle signs will lead you to the diagnosis. Again, pseudoexfoliation, you can see the dandruff-like material lying at the pupillary border and an anterior lens capsule. You can see sphincter tears, colobomas, and seclusio pupillae also. And it is also important to remember that don't only do focus on an undilated primary examination. Even after you have dilated the patient, do a repeat slit lamp examination, because sometimes what is not visible on the primary examination, you can see later on. You can sometimes see this pseudo-exfoliative material on the lens capsule. You can see that classical bullseye appearance, or you can even see glaucom flecken if the pupil and iris are all normal, but the anterior subcapsular changes are there. These are also signs that previously perhaps an angle closure attack has happened. And again, see for the thickness, transparency, and position of the lens and different types of pictures, you will guide you to the probable secondary cause of glaucoma, and you'll know how to manage it accordingly. This is again a case, it just looks like lens matter. You're not sure whether there's lens matter or hypopyon, and you see it is actually a case of phacolytic glaucoma. In cases of pseudophakic and ophakic glaucoma, also it is very important to see whether there is vitreous in the anterior chamber, what is the position of the IUL. One is it will help you to guide your site of filtration surgery so that you can avoid the sites where vitreous is there or where synechia is there or where the haptic is lying there. And if there is frank vitreous, you might even look for macular edema. And in these cases, then you would want to avoid any kind of a PG analog. Slit lamp examination is not only important for anterior segment evaluation, but also evaluation for the disc. So always while you're on the slit lamp with your gonio lens or with your 78 or 90D, also see the disc, which gives you a good stereoscopic view of the disc. And never forget to see the fellow eye, even if the person or the patient strongly complains in one eye, always see the fellow eye. One, to of course see whether there are similar features or not, and second is for the sake of comparison. So at the end, slit lamp examination, as I said, even if you have the most sophisticated tools, you know how you have the OCT angiography or whatever in your hand, slit lamp examination is the basic master key which everybody of us needs to have in hand. A simple, good but thorough slit lamp evaluation will help you to diagnose the case appropriately. If your diagnosis is correct, you will be able to treat the patient appropriately. Sometimes, as we just discussed, your patients are not responding to conventional treatment. Again, a slit lamp evaluation will perhaps help you to modify or find out something which has just developed or perhaps we had missed earlier. And sometimes in complicated cases, again, the moment you see the slit lamp, you find out that this is beyond my purview and my capabilities and skills. So you know that you should immediately refer to the patient to a specialist or to a higher center. So always do a good slit lamp evaluation before you subject the patient to any other investigation. And it's the only master key that leads you well into the world of glaucoma. Thank you.